just share my screen, so just bear with me a moment. Hopefully that's come through. So yeah, thanks for the introduction. My name's Sean Cave, and I'm from a company called Decision Analysis Services Limited. And what we're going to talk about today is using system dynamics for urgent and emergency care. So I've got a few slides just to set the scene again, just to reinforce what system dynamics is, because it may be a new tool or technique to a lot of people on the call today. And then talk about the differences between discrete event simulation and system dynamics, especially for urgent emergency care. And then I'm going to hand over to the really interesting stuff, which is Aaron and Pete talking about their experiences of using system dynamics for urgent emergency care, and then also handing over to Abbie and Amy later from BNSSG. My slides will take about 10 minutes. I think we're going to have Q&A after the sessions as a whole, unless you want to run that slightly differently, Caroline. I'm flexible with either. Okay, so
that's great. We'll take Q&A. Thank you.
Okay, thanks, Caroline. And just to note, I can't see hands up, virtual hands up or anything. So if you need to interrupt me, please do.
100%. I will monitor that, and
okay,
I will come in if I need.
Thank you so much. Okay, so question we've all got at the moment is, what is system dynamics? Well, we consider it to be a modelling approach that's widely used in health and social care that enables complex systems to be better understood and the behaviour over time to be projected using computer simulation. And there's a couple of things I wanted to pick out of this definition that we use. First of all, this isn't new to health and social care. It's been used in many cases over many years, and you'll get an insight into how it's been used over the course of the day. And the two other aspects is, first of all, it builds understanding in complex systems, but also it's got that computer simulation aspect as well. And just thinking back to something that Martin Pitt asked earlier on, one of the key points we do want to get to in most cases is to build a model that projects system behaviour over time and gives us the numbers out, which we can then link to those metrics. But there's still a lot of benefit in that qualitative mapping as well that you build up with a system dynamics model. So just reinforcing some of those SD system dynamics fundamentals again. It's an aggregate view of the system. And the way that we start to help you understand how we as system dynamicists conceptualize these systems is if we just think about a different type of system, think of a bathtub. So for bathtub, you've got a quantity of water inside it, you have a flow going in and a flow going out. And when you're running your bath, what you're trying to do is maintain the bath at a certain level, and you're controlling tap in. So it's a very simple system which we're all familiar with. And the way we'd actually represent that using system dynamics nomenclature is that we'd look at the stocks in the system. So in this case, the stock, which we represent in a rectangle, is the quantity of water in the bath. That's the stock. And we have a flow in, water flowing into the bath, and a flow out, water flowing out of the bath. And we build up these diagrams, system dynamics models, using this stock and flow diagramming. And the final element that we add onto it is the feedback processes. So in our little diagram over here, we've got someone's hand twisting the tap, and what they're doing is they've got a desired amount of water in the bath, and they're adjusting that tap to maintain or reduce the gap between the desired amount and the amount in the bath. And so what we do is we use this way of thinking about the world to build qualitative diagrams representing complex systems, and then put that into a computer software tool to actually do the calculations, put the equations behind those variables. And I'm not going to dwell too much on what those software tools are, but there's a whole range of them. There's paid for versions like Stellar and Vensim, OurSim, Systea, as was, and also there's open source tools. So there's a whole different range of tools that you can use to actually implement those simulation models. And then moving into the health care system, this is a very simple stock and flow diagram representing a very simple patient pathway. So we're looking for those rectangles first of all. We've got a stock of people waiting, a stock of inpatients, and flows in, referrals, admissions to inpatients, and discharges. And then we've got a feedback loop here, which is managing the admissions based on a treatment capacity. And what we do in a system dynamics modelling exercise, we'll first of all build up these diagrams, which, as you can imagine, as you'll see later on, become quite complex system pathway diagrams. but they are understood. They're built with the people in the system, and that helps. So you're bringing that shared understanding together into a single diagram, which represents the system on a page. Now, we've been talking about system dynamics all this morning, but as there's a lot of analysts in this course, it's important for us to recognise that system dynamics is just one of the tools that we can use as part of our analytical projects. And what you'll tend to find is that it's certainly in these type of problems, people will use system dynamics or discrete event simulation tools, and they're both valid. They're both really, really excellent tools for projecting behaviour over time. But there are differences, and it becomes especially important when you start thinking about the urgent care system. And so when we at DAS build a model, one of the really important first stages is scoping out a model and making a decision about what is the appropriate analytical tool to use. And some of our rules of thumb are sort of based on the type of situation or type of questions we have. So reflecting on the comparison between discrete event simulation and system dynamics. Well, first of all, they are both tools that use a time-based model. They look at behavior of a system over time. There are a couple of really, really key differences, especially with respect to urgent care. First of all, discrete event simulation is tracking individual items in the system. So in this case, it would be individual patients, whereas system dynamics is representing the aggregate flows. So it looks at the total number of patients at a point in time and how they flow between the system. In a system dynamics model, you can segment those aggregate quantities, but you're not dealing with individuals. And this becomes important if you've got a problem which is specifically about tracking patients through a system. And they also deal with variation in processing time in different ways. So discrete event simulation, it uses probability distributions and random numbers to generate how long a particular patient would stay in a part of the system, whereas system dynamics uses long-term averages and exponential delays to look at that group view, that aggregate view. So what we tend to do is when we start on a project, we think about what is the right type of modelling tool to use, and not, of course, there's agent-based modelling as well, but if we focus on system dynamics and discrete event simulation, and this sort of refers back actually to some of the one of the slides that Peter presented about when is SD best, and it's sort of reinforcing those points, I think. So first of all, if a situation you're looking at a very large scope, so lots of interacting parts of the system, lots of patient flows between many different types of services, then that draws you towards system dynamics. If you've got a really focused part of the system you want to represent in a lot of detail, then maybe discrete event is more appropriate. If you're looking at long time frames, then that draws you again towards system dynamics. Shorter time frames, for example, what's happening in the next hour, day, week, that draws you towards discrete event simulation. If you're interested in tracking individuals, then that again pushes you towards discrete event simulation. And if stochastics are really important in your model, then again, discrete event simulation sort of draws your attention there. But the great thing about system dynamics models is it handles large numbers of entities really, really well. So if you're looking at a population level model where it's really computationally difficult to parameterize and also just carry out the calculations at an individual level, then again, that draws you towards system dynamics. And finally, where you've got feedback processes in your system, for example, you're looking at how patient behavior might change or clinician behavior. We had the example mentioned earlier on about what does the clinician do if the waiting list is really big? Does that affect the decision-making process? And again, SD, system dynamics, is really good for those type of modeling problems. So that's a sort of bit of a checklist that we tend to use to help us making that decision. But it's not as binary as you might think. Modeling, the scope of a model might be somewhere, it's quite blurry. Sometimes you have aspects of discrete event simulation, typical models, or system dynamics, typical features. And the software tools out there, whether they be open source or pay for, allow you to use elements of both in there when you're defining your quantitative model. So it's a really important part of that analytical journey, deciding which tool to use, what sort of approach to use. And the other thing to bear in mind is that there has been quite a lot of research of late into hybrid and multi-methodology simulation. So actually having a system dynamics model alongside a discrete event simulation model. I think Jenny Morgan's here later on in the day. She's an expert in this combining of different approaches. So that's the tools you might be thinking about. But coming back to urgent care model, which is the focus of the examples we're going to move on to in a moment. Typical sort of problems you might have that you'd use discrete event simulation to address in urgent care modelling is things where perhaps you've got variation over the course of a day, over the course of an hour, and you look at shift patterns, you want to optimise delivery, or if you want to deliver balance staff numbers in different roles and to reduce backlogs over short time periods, and also when you want to understand queuing times against certain levels of staffing, where you're actually interested in that single individual patient moving through the system. The type of urgent care modelling questions that then are more typically used, addressed using system dynamics, are when you're looking at the system as a whole, when you're looking at all the different facilities and services available across urgent care, especially when you think about how people might be routed between those services and how behaviour of the patients may change over time based on the signals they're getting back from the system. And also where you want to take into account that how long it takes for a new policy or change in service delivery to bed in, because often these things take a while. And as was mentioned earlier, sometimes things get worse before they get better, and you want to be able to preempt that change over time. So what I'm going to do now is hand over, I think, to Aaron, who's going to talk about how he and Pete have been using system dynamics to represent some of their urgent care modelling needs.
Thanks, Sean. If you could just take a quick look in the chat whilst Aaron is presenting, there are a couple of specific questions for you. Thank you.
Thank you.
Thanks, Sean. So I'll just share my screen and the slides.
That's all going beautifully, Aaron.
Fantastic. You can see it okay? Great.
Absolutely great, yeah.
Oh, sorry, I've lost it already. I want the lemons on the other screen.
It'll be
I'll
back.
do it this way, it's easier. So my name's Aaron, I'm an analyst at the James Paget University Hospital. We're part of the Norfolk Waveney ICS, and we became involved in system dynamics last year.
Aaron, I'm sorry to interrupt you. Would you mind going on
you're losing me.
View?
I'm so sorry.
Don't worry at all. It's just it makes it a little bit bigger if it's on slideshow view. And then we can see it a little bit better.
Is that working now?
Just hop onto slideshow view, that would be perfect.
Click on,
we've got you, perfect. That
every
is
time
wonderful.
I want to do
Thank
it, it's
you.
changing my screens around, which is very
I know. Tech is our friend and otherwise. So, but thank you for persevering. That is wonderful.
So you can see it properly now. Great. So again, my name's Aaron. I'm an analyst at the James Paget Hospital. We're part of the Norfolk and Waveney ICS. We have 3 acutes and loads of other organisations. We became involved in system dynamics last year, and our pilot was the MSK model. And there were a few reasons we decided to become involved in system dynamics. The first one was we were already working together as a system, but we didn't have the kind of modelling capability to bring everything together. We were talking about single PTLs, sharing workload between the 3 acutes, but we weren't doing it. And we needed a way of being able to do that. We wanted to improve the analytics team between all of the organisations so we could work together further and more collaboratively. And there was a knowledge gap. We didn't have the skills to do modelling. We did quite simple Excel models, didn't give the users a lot of ways to engage with, and we could do better. So our journey so far, we did the MSK pilot last year. That's available on the NHS Futures Demand and Capacity site if you're interested. We then went on to look at dermatology and ophthalmology as specialties. My colleague Ben at Queen Elizabeth has almost completed our dermatology model. The ophthalmology model unfortunately got stalled because of the COVID when it escalated again last year. And we decided we were going to review our approach. We felt system dynamics was great. It could offer a lot of capabilities in our ICS, but we really wanted to do something at a very, very high level to prove its worth to everybody in the ICS, all the organisations. So we decided we were going to look at UEC and elective recovery. So Mike Peet, who's the head of Insight Analysis over the whole of the ICS, is going to talk about the UEC model in a minute. I'm currently working on elective recovery. They're both very big projects, but I think they have a lot of potential. And just to say that system dynamics is really, really interesting. Since we've been involved, there's so many possibilities that we can use it for. I think there's a lot of really interesting talks today that I'm looking forward to. We believe if we get these two over the line and can prove to everybody how great it is, we can use it in all sorts of organisations in areas. I know people have said, should it be an ICS level? Should it be a trust level? I think it's everything. It can be used from very, very high level system-wide view across the ICS down to really specific pathways and individual keeps that make up the trust. So I'm going to pass over to Pete to show you the actual model now.
Thanks, Aaron. So I think some of you have seen me before, but for those of you who haven't, my name is Pete Best. I'm Head of Insight and Analytics for the Norfolk and Waveney ICS. As Aaron's described, what I'm going to do is just show you what the model looks like that we're developing so far for UEC. And I'm going to, rather than do it in a slide show, I'm going to actually show you the software in it, which will allow me to move around a little bit more clearly for you. I will caveat it to start off with by saying this is a work in progress. This isn't a fully working model that's been completely tested yet. And I just want to be really, really clear on that as well. It takes quite a long time to develop these models, and we need to get quite a lot of engagement from different organisations to be able to do that. But we're just on the cusp now of being able to sign off a permanent system dynamics analyst to start taking this forward for our ICS, which is a really good step forward and will allow us to continue that on. Without further ado, I will share my screen. So I'm hoping you can all see that. No one has said no. So
yeah, that's perfect. Thanks, Pete. That looks great.
Thanks, Caroline. So for those of you that haven't seen it, this is something called Stellar Architect. So this is a software that we chose to use to do that. What this does is it's the actual drawing program that allows us to draw pathways and make models similar to how Sean showed you beforehand with the stocks and the flows. Stocks being the square boxes and then flows coming off the different angles. Whilst it looks complicated with arrows all over the place, they just show the interdependencies between some of the different areas that we're looking at. But what I'll do is I'll just talk you through roughly how we build the model and how it works. And then I'll show you how customers will actually interact with it, because that's probably one of the most important bits here. This is great from an analytical geeky perspective, but it's got to be suitable for the audience later on. So starting here, what we can see is we've got demand coming through, and I'll zoom in a little bit so people can see. We've got demand across the whole system coming into the urgent emergency care. So we've got different ways of doing that. Some may be that we're working with our public health colleagues to do a forecast about what do we expect demand to look like. Sometimes people just want to put in a manual growth rate of, we think it's going to increase by 3%, and we want to see what that impact will be. Or sometimes we just want to do a straight line forecast. We've built in all of those different options so people can model different approaches. That then pulls into a pot of people. These are people with healthcare needs. And this models a 10-year period. So 3 years historic and then 7 years going forward. And the reason for that is to allow us to undertake testing on it to make sure it's right. When we've identified these people who are going to need emergency healthcare needs, we've said that there's about 6 main routes they're going to go through. Now, there are a few additionals that we could consider, such as pharmacy. But in the main, we've looked at patients going to 111, phoning 999, going to their GP for an urgent appointment, the walk-in centre, a minor injury unit or ED. So we can see here that patients flow through to each of those. Once we start to interact with them, though, we can click on these individual modules, and each of these modules then builds up a pathway of what patients would experience when they go through that at a relatively high level. So again, it looks complicated, but it's really not. At the moment, we have demand coming through to 111, so this is people calling 111, and either the call will be answered, in which case they'll go on to a non-clinical triage, or the call will be abandoned because we haven't answered it. If the call is answered, they will go have a non-clinical triage, and there'll be a few different routes from there. They'll either be given advice and guidance, and that will end their pathway. They'll be referred on to ED, they'll be referred on to GP, so on and so forth. Or alternatively, we may refer them on for clinical assessment. And what we're able to do is look at historic data and apply the proportions of people to do that, which will then allow us to forecast going forward what will happen. They have a clinical assessment. Then again, you can see lots of different outputs there. They're slightly broader than the first ones because, of course, it is a clinical assessment. What we also looked at is for those people who were abandoning calls. This was really important to us as a system because we know as healthcare demands increase, we don't have enough resources to cope with that. And when that happens, people are going to seek alternative options. They don't just leave the system. So where it's abandoned, we're saying that they may seek an alternative solution for that care. So those patients might go straight to ED, they might rephone, or they might actually give up. But you can see each of these different areas here goes off to one of these little cloud pictures. And essentially that means that it's ending that flow there, and then we're going to join it back in to another area later on. So if I pick another example so you can see what I mean, we can look at 999. So again, it looks complicated because there's arrows all over the place, but in actual fact, it's just a simple flow where we've got people requiring 999 support. Either they'll have an ambulance, they won't need an ambulance. They'll either be conveyed or they won't be conveyed. And each of these different areas around it are areas where we can have flows coming in or where they allow us to configure it slightly differently. So proportions of people needing 999 care, proportions needing conveyance, we can adjust those throughout the model so that people can work in a different way. You can see all these areas here with the hashes around it. These are all the different flows in, and it's really important to just reflect those because it shows how interdependent all of our different systems are. This isn't just people phoning up 999, but it's people phoning up 999, it's people being referred in via 111, via ambulances, via MIUs, via walk-in centres. And what this means is that every of the individual components of this, when you change something, the route of those patients will change, the proportions will change, and they will impact another service. And I think that's where the system dynamics modelling really helps. It allows us to change one small aspect and then see how it affects everything else. I won't go through all the pages because you'll get the gist of it. It is a flow through. But what we will move on to very briefly is the acute admission side. That's slightly different, so I'll show you that very briefly. Patients are coming into an acute hospital. They're going into theatres or they're not going into theatres. We then can choose what bed type they're going to go into. And this is where we get some real constraints coming in, the availability of beds and ring fencing for elective care. They will then be discharged, and a number of them will go on to discharge to assess pathway, so move on to community care or social care. And again, it's modelling that through, so it gives us that whole picture. So that's roughly where we are, and that's roughly what a model looks like. Complicated but simple at the same time. However, you can't give this to a customer. They're not going to be able to cope with this at all. So what we do is we build an interface for that. So I'm just going to put that onto my screen as well. What this shows us, what this is a customer interaction. Let me just zoom in so you can actually see it properly. This is the way that a customer would react to your model and would be able to interact with it in order to test their own scenarios. And this is then produced and published on the web-based portal. So it means that any customers that you want to have access can have access to this, and they can go away, configure it, change it, and run it as many times as they want to. They can't break the model, which is a really good advantage to this. We've got the introductory page. We then move over to give them a picture of the model, so people that want to explore and understand it can explore it. But then we have the interactability around this. Let me try and make this a little bit larger. This, for example, hopefully you can see this well enough. I'm hoping you can. I'm trying to zoom in, but it's cutting off a little bit, so so bear with me on it. This is a page which is showing UEC demand as a whole, and we can see on here there's a bar chart on the left-hand side, and this shows where people are choosing, so the different aspects of UEC that they're wanting to contact. So 111, GP appointments, etc. It gives us a flow across the 10-year period to show what's going on, and then some different configurabilities. What I can do is I can run this model, and what it will do is it will produce information and will produce a forecast for me based on the information we've got, which is great. But what customers can do is say, actually, we don't want a manual growth rate of 1.2%. We don't believe that's right. We actually think it's going to be 5%. It's going to be really busy. So they can change that to 5%, and they can run that again. What that will immediately do is it will overlay the existing information with that to show you the impact of that. And you can look at that for all the different aspects of the service that we're providing. What we've also got in here is which route are people going to pick. And we can see that we've got a calculated figure, which we based on our information, which you can't quite see on the page, but just pretend you can do. What we've also got the ability to do is be able to click on a manual one. So we're going to change it, and we want to expect something different to happen. So if we say, we really want people to phone up 111, we want them to stop pretending ED all the time because it just doesn't work. We can change that and we can say only 10% of these UEC people are going to go to ED, and we're going to add that 15% in to attend 111. They're going to call them. We can say we want that to take that place in a couple of years' time. So we'll say that's going to take place in week 250. The reason why it's 250, of course, is because 3 years is historic, and therefore this is about 2 years in the future. And what we can then do is we can run those parameters again. And we will then see at that point in time, there's a marked change in that. So it allows people to start to configure it. The different pages, again, I won't go through them all because you'll get the gist again. But you can see for each of the different aspects, we've applied this same sort of principle whereby people can start to interact with it and they can start to change the different variables themselves. But importantly, you'll note that the information which we adjusted on the first page carries on over. So this is one complete model. And if you change that aspect, all of those different parts will flow all the way through. So we have these many different pages on here. You can see, though, it's not quite complete. What we will do as a final page at the end is provide a summary picture of what are the different inputs, how has that changed from our current position to where we will forecast to be in 3 years, 5 years, 7 years, 10 years time. And that will allow people to very quickly play the model, make adjustments, make some strategic questions around it, and provide information for the output. The model itself is high level, and it's deliberately high level. It's not trying to get to following every single patient about it in a discrete event. But we hope this will provide enough information for people to make strategic planning decisions around it, and then hopefully commission more detailed models as and when we need them. It's the same as what Aaron described with the elective recovery. We're producing a high level model, but when we find a specialty which is really struggling and they've got a slightly more nuanced pathway, we can of course go away and explore that in a little bit more detail. Hopefully that gives you a brief view about what this looks like, about how it's built, and about how customers will interact with it. But happy to take any questions.
That's fantastic. Thanks, Pete. That's great. And a lot of love for your model in the chat, which you might like to take a look at, and some requests for things like screenshots. So if you perhaps could think about adding some of those to the final slide pack, that would be lovely. Bit of a question about some specifics around the model about can you look at things that might help you to manage demand? So better prevention or better SDEC services, and also just some questions about how might the model pick up on things like abandoned callers? Any thoughts about any of that?
So in terms of changes in service, yes, that's really the idea behind this. I think with any change in service which you've got, you can change that to be a quantitative change within the model. So if we choose to make a change to a service by adding in different triages, for example, what that would do is it would change the proportions, choosing each of those different services or choose the outputs. So we're turning each of those plans, those changes into a configurable number which you can change and adjust it as you need to. So yes, that is absolutely built into it. I'm afraid you're going to have to repeat the second part of the question because I've forgotten it by answering the first one.
No, not at all. So that was really about callers who abandon, so callers who drop out at the kind of 111 part. Is there any way of kind of monitoring that, and what might make a difference to that? And
so at the moment, the way that we've built the model for abandonment rates for 111 as a specific example is you can make it slightly more intelligent than putting the set number. So let's say it's 2% at the moment. You could then say it'll be 2% and it'll grow. We don't really want to do that because we know it's slightly more dynamic than that. So instead, we've related the abandonment rate to the demand on the system. So the greater the demand on the system, the greater the abandonment rate on it. And that reflects that we've only got a finite amount of resources. So it tries to become a little bit more clever with that. And that means you don't always have to configure everything yourself. Sometimes a model will do some aspects of that themselves. The way we will actually configure it and we will build that correlation is by looking at real data to try and identify what's going on with it. But of course, the data isn't all completely in here yet, but it's built in, it's designed for that specific reason.
Brilliant. Thanks, Pete. And a little bit of a question that kind of links on from that, I think, from Anthony, to just say, is there an opportunity to run any of this in near real time? Using feeds from source data, perhaps, to start looking at performance, looking at sort of hotspots, or is this really a kind of something that you look at a bit longer term? Maybe we talked about SD being perhaps something that's a longer term, but I guess
yeah. So we
question about.
we've specifically designed this to be a longer term model, so
Yeah,
more of a
sure.
strategic modelling.
Yeah.
But what our intention is once we have this and we understand it, we can then start to build more real-time dashboards off the back of it, so we can understand the correlations and the relationships from that, and that allow people to monitor it. But this tool, in the way it's been built, wouldn't really do that, because it doesn't follow the individual patients through. It just follows a scenario and averages and percentages.
Brilliant, thanks, Pete. There are lots of other questions for you, which if we have time, we might come back to. But for now, if it's okay, we'll pass on to our friends and colleagues from Bristol. So we've got Abbie and Amy, I think, joining us next to talk through their experience of using a UEC system dynamic model as an analyst and from an operational perspective. Abbie and Amy, are you with us?
We're here.
Fantastic, lovely. Can we invite you to join us and to share, and we will then come back for some more questions later.
Sure. So we thought it'd be good just to give a kind of overview of kind of why we decided to use system dynamic modelling and what we would actually decide to use it for. So I'm Amy Cost. I'm a UEC programme manager within the ICB at BNSSG, and the idea for the pilot came through our minors programme, which primary aim was to look at how we reduce low acuity activity within our EDs. As we know, they're completely under pressure, and kind of we have certain interventions that we had in our plans already to do. So system dynamic modelling was a way of us working out kind of where to put our time, effort and resource, what was going to really have the true impact, and look at those kind of longer term strategic objectives for us as a system. So the question, if you like, that we kind of framed the pilot for was, how do we address the flow of patients across our system, reducing minor activity, obviously with the kind of intention of improving the healthcare system for our patients fundamentally, but kind of taking consideration our existing capacity and workforce challenges. We kind of focusing it on kind of two areas. So for us, it was about the impact of triage, assessment and routing. So when they enter our systems, how do we stream them to the right services? And for us as a system, we have our clinical assessment service, which is connected to our NHS 111 activity, which are able then to kind of redirect patients across our system, and then also kind of via our existing streaming mechanisms, and also the introduction of the ED streaming tool, which we are looking to kind of implement in our system. The other part was the impact of having the right downstream capacity in our system, which we all know is vital. It's all well and good having something shiny to direct people to, but if there's not the right services at the end of it, it doesn't work very well. So that's about looking at our UTC MIU provision. You know, are they the right size? Are they open the right hours? Are they in the right geography? For us, you know, really big kind of questions that we really would like to stop kind of us making assumptions about and have a little bit more evidence driven behind, and then looking at kind of the opportunities of improving our community pharmacy consultation service capacity. You know, do we have the right size primary care, which I'm sure people will all say no, but you know, how much do we actually need to deal with our activity? And then obviously the opportunities for SDEC, and are there kind of big ticket items or larger cohorts of patients that we could really be streaming through those pathways? So some really big questions, and I've put a couple of the what ifs at the bottom, as I think we identified really early on for us is that scope is really important, and being really clear about what it is we're trying to get out of the modelling early on not only helps your poor BI analysts who have to do all the legwork, but also really frames it for your system about what you're going to be using the information for when it's done. And I think that's one thing that we've really been committed to in BNSSG, is to really spend the time to do it right, because we do want to make some strategic decisions post the pilot, and so we need to make sure everyone owns it. So I obviously give a high level to that. I'll pass you on to Abbie, who's been doing all the hard work in our BI team.
Hi, thank you, Amy. So I'm Abbie. I'm the principal BI analyst for the BNSSG ICB, mainly focusing on the urgent care area. So yeah, we decided to get involved with this because we thought it was a unique opportunity to better understand the urgent care system as a whole, and make projections using computer simulation. So it's enabled us to create diagrams that show how the various services within urgent care all link together, and it will give us an idea of the resources required to deliver them. The diagrams can then be converted into simulation models that can be used to calculate the impact of changes to how the services are delivered. So yeah, this wasn't something that we've ever done before or that we've ever been able to do. As kind of Pete mentioned before, we've kind of just focused on more segmented areas of work, individual trusts, rather than the system as a whole. So yeah, we had no prior experience of developing system dynamics models, so it's all still quite new to us. We're a lot further behind in kind of the development stage than Norfolk and Waveney. So yeah, so we've been given the training recently at the same, and so we were given the training alongside starting to create the UEC kind of model, which meant we were a bit kind of slow to get started, and there was a lot of kind of creating models that weren't quite right, so we would have to change the approach quite a few times. But I feel like now we're really starting to get going with the model, and we kind of know the approach that we're going to use. So yeah, it's nice that we're kind of starting to see it come together a bit more. So that's great. One thing that I would say is that there's been a lot of kind of competing demands that meant completing this work has been a bit difficult. Originally there was kind of going to be a team of us analysts working on this, but it's mainly ended up just being me that's been involved in this work, which is, yeah, and it's quite a big commitment. So I think it would be great if there's a team of analysts to work together on it. Because yeah, I've been involved in kind of every aspect from obtaining the data, formatting it in the correct way, as well as then kind of creating the model in Stella. So yeah, I would advise in future kind of splitting up the tasks between a team of analysts. I think it's key as well just to point out, like Amy said, it's good to make sure that you've kind of got the requirements and the ask sorted before you start the modelling. I think that's definitely kind of a necessary point, because otherwise you kind of do end up kind of creating the model, and then you do end up going a bit backwards and forwards, and there's a lot of stopping and starting. So it is good to kind of make the asks clear before you start this. And I would say that the urgent care kind of system, it has been a bit of a challenging place to start just because it's so complex. I would recommend kind of starting with a smaller project. But yeah, in order to deal with this, we did similar to Norfolk and Waveney, and we split kind of the urgent care system into different areas, including kind of 111, ambulance, ED, etc. And then we've gone on then to meet kind of system partners involved in each of these areas and services, just to help us identify the kind of inflows and outflows in the model, and then again, kind of exactly what they do want to focus on. So yeah, we're continuing to meet different partners to discuss the data, especially kind of because we've got areas where we've got missing data. So we've been able to speak to them and kind of get some rough proportions and estimates for different areas that we've been able to use in the absence of certain data. But yeah, the model's taking shape now, and we are really excited to see kind of where this is going to go, and the results of this. I think it'll be really useful for the system. So yeah, I was going to also show our model, so I can share that with you now. Just get that up on screen. There we go, you should be able to see that now.
Yeah, that's up now, Abbie.
Perfect, thank you. So our model, just to say again, we're in still really early stages in comparison to Norfolk and Waveney. So currently we've just kind of modelled the current urgent care system as it is now. And then kind of going forward, we'll obviously add in the ability to kind of add in kind of changes to the system and future predictions. We've also done the same time period, so we've done 3 years historic and 7 years into the future. Yeah, so I guess one main difference in our model is that we've focused on a lot on 111, because as Amy said, we want to focus on the system clinical assessment service, CAS, which is kind of a validation streaming service within 111. So I can zoom into a section of the model for this 111 section. So yeah, you can see again, we've started with the 111 calls answered and the input, and then we've split it up into the triage method. So whether they're triaged to ETC or Cat 3, 4 or other. And then following that, we've kind of then got the validation service. So one of them being system CAS. And then we've got the outputs from each of those validation as to where they were referred to. So that's our 111 page. And then again, obviously we've got each separate segment split up. So we've also got ED, which is going to be one of our main focuses. Yeah, an ambulance. But yeah, so ours is quite basic at the moment, but I think it will kind of have a real impact going forward, and looking at kind of changes to the services.
I think, Abbie, what we realised early on was there were like more questions after we defined our scope. So in terms of kind of how much detail do we actually want to drill down into, and I think we were talking about, someone mentioned a PCN level into our GPs, and I think everyone had some cold sweats at the thought of the number of flows that would kind of be required to do that. And, so as a system, we kind of thought, made that agreement that actually on a locality level would be sufficient for the kind of what we want right now, with the kind of understanding that we've always got the opportunity to do further modelling down the line. But in terms of those bigger strategic questions, that would be the scope for this piece of work.
Yeah, that's a good point to make. So yeah, defining the scope was a really big starting point. I think a lot of different kind of service and system partners suggested a lot, like so many different things that we could model, but we had to get to a point where we just focused on certain areas like system CAS and ED redirections, rather than going into details of specific services such as mental health services and community services. So it's really important to define kind of the initial scope, and also defining again the data that's required. So we have ended up kind of splitting all of our data feeds by locality and age, because I think we also really want to see the differences between adults and children. So that's kind of what our model has focused on as well. Yeah.
Thank you. Are you happy to take questions?
Yeah, go for it. If anyone's got questions.
Thank you very much indeed. And it doesn't look like a basic model to me at all. It looks like you've done great things with a very small team, which kind of pulls us back to one of the questions up at the very sort of as we started off today, where people talked about the difficulty of getting support for proper analyst time to build models like this, etc., etc. And there was a lot of kind of thumbs up around that particular quote. I wondered if there was any reflections that anybody had on that you've presented to us today, any hints and tips on how to secure proper support to build these models, and just welcome any thoughts on that, either from our panel or in the chat. Pete, come on in.
So blackmail seems to work quite well, is what I'm finding. I think from my perspective, so when we started this piece of work, we a bit like with Abbie, we thought we were going to have a team, we're going to have lots of dedicated time, but the pressures of COVID and the winter coming means it's just not practical to do, and people are pulled away on other pieces of work. We started off with a small model, the MSK model, and that meant we had a really small customer base, and it meant that although we started interacting with people, we couldn't quite get that buy-in, because the buy-in is only from 2 people and they can't control the funding. And that's why we moved to kind of broader opportunities. The way that I've started trying to get funding is by half developing these models. So the UEC model is something that I developed in my time when I had it, the same with the elective recovery. But by developing something and starting to show the credibility of it and what it could deliver, it means that people can actually start to understand it and start to invest some more time in it. As a result of that, we should be getting funding for a post. If we can do that, we can prove the concept, we can prove the value for money and go from there. But I think this is a very different approach, and people can't always understand it. It's also not that quick, and the typical result is buying a contracting company to do this for us. And if we can get these skills in-house and share the value, we own it and we maintain it from there. So that's what I do, proof of concept, and try and get that buy-in.
Fantastic, thanks, Pete. And did you want to come in as well, Peter?
I wanted to reflect on an implied sort of statement. Abbie was talking about the scope, and it's an impressive scope that you've designed, that you've built there, but actually sort of calibrating that to the real world can be difficult. So I just wanted briefly to reflect on my earlier comment that scope creep should be sort of balanced with issue definition. And if you've defined your issue as how do we manage the whole of the urgent and emergency care system, then of course you will build a very large model. If, however, you define your issue a little bit more focused, like how will change X impact on flow Y, then it can be more manageable, more demonstrably beneficial. But what you've got to do then is be transparent about that with your internal clients that say, well, in a sense, we're conducting a bit of a scientific experiment by saying we're going to change this, all other things being equal. And we know that in the scientific world and in our world, all other things are not always equal, but at least it's transparent to people that says we can show the benefit in a slightly more focused issue definition with things that are material to that issue, but that then hooks people in and says, well, actually, and without the danger of sort of complete sort of overload and mission creep, but build different bits, if you like, which might be a sort of lesson in hindsight, but that's hopefully helpful.
Yeah, that is indeed helpful. Abbie, do you want to come in as well? Abbie, you're on mute still, my lovely.
Oh, sorry, thank you.
No worries.
Yeah, so I was just going to bring it back to the fact that obviously as an analyst, kind of I've never done modelling before, and it is quite a lot to kind of get your head around. It's a whole new kind of way of working, I guess. And I was doing this alongside my normal kind of day-to-day job, which I did find quite tricky because of the different kind of headspace. But yeah, I definitely think, obviously, if you can get funding for an analyst, as Pete's done, I think that is a great kind of idea.
Thank you, and a lovely shout out from Tina in the chat saying your regional team leads may know some opportunities for funding, etc. So do reach out to them, reach out to Tina if you're not sure who to reach out to in your own region, and I'm sure she'd be happy to signpost you. So thank you for that and for people's observations in the chat about this. Stephen, did you want to come in?
Yeah, I've got an observation about the pilots. So typically, in order to get funding to buy the software and spare people's time to do the pilots, you need to sort of promote answers to big questions. I think most people building their very first system dynamics model would say that you really want something quite small, that you can do that learning very quickly, have something achievable, and then really put your effort. Your second system dynamics model will be better than your first system dynamics model. So actually the big questions is better to say, okay, if you fund me to do this, if you buy me the software, let me learn on something small and achievable, and then I'll start to answer the big questions on my second system dynamics model. And I think probably Pete and Aaron would say, you know, they're now building their second and third system dynamics models, and they probably look different to what they would have built if it had been their first system dynamics model. So that's, I guess, a plea to people thinking about funding the pilots is actually, you know, just think about the journey to getting the model you want, and not necessarily trying to get it as the very first SD model that gets built.
Thank you, Stephen. That's great advice. interesting reflection from Bruce in the chat, and thank you for that, Bruce, which is that 3 years historic data takes in the whole of the COVID period. So how have you adjusted in terms of your models for that, if at all?
So if I try and answer that, so we haven't really adjusted it at the moment. The reason why we use a 3 years historic is really for testing purposes, because we know where we started from, we know the actuals which have happened, and we can make sure that data then flows all the way through. I think when we're starting to do the forecasting forward, what we don't want to do is just use the last 3 years as an average, because yeah, quite rightly, with COVID breaking into it, that would cause us some issues. So we need to be slightly more intelligent about that and talk to the customers about what the realities are. And I think that's where the customers can interact with it, and they can overwrite it as well with their operational experience, as opposed to just what the data says. So we haven't adjusted for it, but we've built in adjustability to account for it.
Brilliant, thank you. Any reflections from the Bristol, North Somerset, South Gloucestershire team on that? Anything you're thinking of in relation to your 3-year historical data and the COVID impact?
So similar to Pete, we've kind of we've not done averages, we have done the whole time period. So obviously you will be able to see the fluctuations during COVID in there. And then where we have done averages, we've just done averages from I think April 2021 onwards, rather than including the COVID period for the averages.
Brilliant, thank you so much for that. That's absolutely great. Just one final question, if we may, which is that we've got people on this call who are obviously very, very technically able, and then you've got people like me who come from much more of an ops or a clinical background, and a little bit of a sort of thought reflection from Helen in the chat saying, I'm not an analyst, I'm finding this useful and interesting, but are there any things that you think you would like to say to people who come to this as a kind of interested amateur and thinking about how they might use this in their services, and where should they start and which bits of it could they use for their own service thinking, if you like? Pete, if you're talking, you're on mute.
Perfect, thank you. I'll try and fill the vacant space. I love talking, as you will have gathered by now. So in terms of technical skills, I am not a technical person at all. I can't use SQL, I can just about use Excel, I can't use any of our PAS systems either. But actually the software itself, it's about drawing a business process, and it's about linking flows up. So I don't actually think you need to be a detailed analyst to undertake that. I think you will need BI support in order to get the data at the back end and maybe write some of the more complex formula around forecasting. But in terms of starting to sit down and think about what solutions you want to solve, what your processes look like, you really don't need to be technical, otherwise I wouldn't be able to do it.
Yes, and Helen had some nice observations herself about perhaps, you know, being part of or bringing together a stakeholder group to begin to sort of, you know, start the process and talk about the spec and what's in scope and what's not. And yeah, it's great. Thank you. Helen, did you want to come in at all? I can see you popped up on screen. No, you're good. Okay, that's fine. Thank you so much. That's absolutely brilliant. Anything you would like to bring in from the Bristol side on that?
I think we covered it really. I think, you know, like I say, I think stakeholder engagement is really important. I think, you know, if you're going to put a lot of work and time into something like that, you really want your stakeholders to really engage with it and kind of recognise it's their flows. So I think that's why Abbie was saying, you know, I think they've kind of on reflection, they've decided to take the individual parts of the model to the actual provider to go, can you sense check this? Do you recognise this? So when you do show the larger scale model, you know, everyone is kind of along with you on that journey. So you're not just kind of giving them a scary looking model that everyone kind of finds a bit intimidating.
Yeah, brilliant. Thank you. And last question, if we can. We've got 5 more minutes, so we'll just pop in one more for you, which is a lovely question from Alison about the creation of sort of subsystems and kind of linking those into your system dynamic model, so you get a sort of almost like a hierarchy in an SD model. Anybody done that? Anybody got any thoughts about that? How different parts of a system might fit together? Peter, I've seen you come off on camera. I don't know whether that's a question around sort of subsystems and linking into that sort of hierarchy might be something that you've thought of at all.
yes, and done, and I mean, depending on what software you use, you've had a couple of examples this morning of Stella. The use of modules and turning modules on and off is a very helpful little function that may be available in other software as well, and it does enable you to just think about one system, one bit of the system. You know, my comment earlier about all other things being equal, but there's still a risk of combining too many bits of a system, trying to sort of pursue this goal of a model of the rule of everything, and I just don't think that ultimately works. There's still a sort of scope creep issue. One of the challenges that you'll have in terms of building models is different time specifications that you might include. Is this a 3-year model, a 5-year model, a 3-month model? And if you start to get sort of muddled between the two, then it's best to have separate models. Douglas has put a comment in the chat, also very experienced in this. Build lots of small models, he says. We've also built models that speak to each other, which means that by which I mean Vanessa mentioned earlier on in terms of population health measures and models tend to be very long-term, 10, 20 years, but you can export data from that then can be an import to another model that might be over 3 to 5 years, and then you can deal with the inconsistencies. So keep focused on an issue and a time spec and a sort of scope. And then you can choose to do modular or just sort of speaking to. That's also true with Sean's comment around the speaking between a DES model and a system dynamics model. We've done projects where it's been appropriate to model the operational with a DES model, but then you export data from that feeds into a more strategic model. So those are some tips, some experience that we've had in that field.
That is brilliant. Thank you so much. And another really fantastic, really interactive session there. Thank you so much to people who've been popping their thoughts and their offers in the chat. Thank you to people who've offered to connect with others and help them.